This is a case of 4 years old gentleman with large inguinal irreducible scrotal hernia. The BMI was 45. So in these kind of obese patient, to doing a TEP is really challenging. These are the ports, 3 ports, and then the diagnostic port. As we entered inside, you see that what is important in this obese kind of a patient, you have to go between the 2 layers of the fascia transversalis if you really want to go in the right plane. And after that, by using a 30-degree telescope, we have made 2 other ports and doing the dissection. Now you see I'm going on the right side and trying to define a sac which is a very large inguinoscrotal. It was almost going up to the mid thigh kind of a thing, and the contents were omentum. So intentionally, if you want to do this TEP, it's not easy. Many people do it ETEP, but we normally do TEP. We open the sac, because when you open the sac, then the omentum comes down. But in this kind of case, it was so irreducible that after all the traction from below the scrotum and the above, we were not able to take the omentum down because it was adherent to the scrotal sac. So then we decided, after great manipulation, to do a diagnostic lab, and then we went in and saw this thing. Now you see the amount of the force we have to apply in still trying to reduce it. So these are the kind of a thing which you have to do. Normally they get reduced on their own, but it was impossible. So by gradual traction, using of harmonic, the small fibers were cut and try to getting the omentum down. With lot of manipulation and all, we were able to get the omentum down. So this is again, if you see the amount of struggle going on, but you have to be very gradual, take your time, no hurry. And by taking these small attachments, slowly the omentum tries to come down. Sometimes you have to transit the omentum also, so you can remove the remaining percent of the scrotum. And in one of the cases, we have to do a scrotal thing to remove it, but in this it was okay. See, the kind of peritoneum is so thin. That's why we prefer doing a TEP repair, because if we do a TEP repair, the peritoneum is so thin, sometimes it gives ways and then becomes an issue. Now we are trying to define the sac, which is very large, huge. The most best trick is to go as up as you can. If you go up, then you reduce the size of the sac and it becomes like a gripping thing. So this is, I'm trying to go as up as possible, and after defining the sac, which is the huge thick sac you are seeing, this harmonic really helps. We are able to transit the sac as high as possible. Otherwise, it will be very difficult to get it down. So this is the transition of sac. This is the space of Ritzius you are saying. Now we are trying to get the peritoneum down. And on the other side, be near to the peritoneum, because if you are away from the peritoneum, you will remove the fascia transversalis over the psoas muscle and expose the nerve. So be always near to the peritoneum. In this way, you can have a good layer of fascias over the psoas muscle, so nerves are all intact in these kind of. The most important is to mobilize the sacs in this, because if you don't mobilize the sac, you will not be able to close it. So I'm trying to mobilize the sac as much as I can. There are 2 ways to do it. You can suture it, but people, if you are getting a good grip, you can even and apply the endoloop. So here, if you see, we apply 2 endoloop after gradually mobilizing or peritalization of the sac, because then only you get the grip. Try to define where the vas moves medially, and the second endoloop was applied to completely close the sac, which you will see when I'll show you the intraperitoneal picture. You see the sac is totally closed. Then we went on the other side, and the similar thing was done on the other side. A lot of fat because of the 45 BMI of the patient. TEP is not easy, but as we are used to for so many years, because we started as a TEP surgeon, we do ETEP also, because we feel that in certain cases like this, if you do ETEP, people who don't do ETEP, this is the way how to do it at TEP, but ETEP will be differently preferable in such kind of large inguinal hernia. This is, I'm trying to define on the other side and getting the peritoneum down, and always follow the peritoneum. Don't be near to the psoas muscles, because that peritalization is very important, that you don't expose the nerves over the muscles. Otherwise, it will lead to chronic pains and everything. This is how the picture looks after we have done it inside. Then we put a 15 by 12 centimeter mesh on both the side. You can in fact put a 16 by 12 3D meshes also. and both the things can be done. This is how we prepare the mesh. About 5 centimeter is below, covering the space of radius, and so it gets a good coverage. We normally secure it to the Cooper's ligament. So in these kind of large hernia, the mesh doesn't fold from the medial side because most of the recurrence are on the medial. And above the iliopubic tract, we define it and put one more to fix the mesh, because in these kind of large hernia, fixation of mesh is very open. Then we unroll it on the floor. It is on the floor, becomes the roof. So there is nothing like floor and roof. Ultimately, the peritoneum has to go and tuck it. And this is the internal picture what we get after this bilateral repair, which, thank you.